Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying about a very important topic, and India is the leading cause of tuberculosis, and tuberculosis is such important topic that either it can be asked as a long answer or either it can be asked as a short answer. Either in your microbiology, either in your pathology, either in your pharmacology, because it's so important. Okay, so let's study. So tuberculosis is nothing but a chronic granulomatous infection caused by a Mycobacterium tuberculi that we all know. What is it? Is one of the major public health issues in India, and you know what? WHO has end TB strategy that you read in your PSM. It aims for 90% reduction in TB by the year of 2030, and now it's 2025 going on. I don't know by how many times we will be able to eliminate TB. Okay, then you have the etiology, the causative agent. You have the Mycobacterium tuberculi, that is you will do they are basically the acid-fast bacilli, that is why you use the Zn stain for that, right? Other species are M. bovis, you have M. africanum and M. macrophages. So you will read this in your microbiology in very much details. What are the properties? They are acid-fast due to mycolic acids in their cell walls, like these are the cells. So in the cell wall, they are having the presence of mycolic acid. Okay, so that is why they are acid fast. Transmission is mainly by airborne droplets like inhalation from coughing, sneezing or speaking. The other routes are ingestion, like ingestions of unpasteurized milk. That is why it is very advised to you, whenever you take milk from anywhere, it is advisable to boil that milk for around 30 to 40 minutes and for around 1 hour. Okay, pathogenesis, what will happen? The organism, there will be entry of that organism. After that, they will disrupt the alveolar macrophage. As a result of what will happen, there will be the activation of cell mediated immunity. After the activation of cell mediated immunity, what will happen? There will be CD4 plus T cells that will come into the activation, and they will activate your macrophages. I don't know how many times we have read the same thing, and please memorize all this pathogenesis very carefully. Okay, that will lead to the granuloma formation. We have read about the granuloma formation in the granulomatous lesions chapter as well. If you are not very well versed with that, please go and watch that video. Okay, so you have the types of TB. First one that you have is the primary tuberculosis. What happens in the primary tuberculosis? There is first infection in previously unexposed host. Okay, in the primary tuberculosis, the tuberculosis is occurring for the very first time. What is the part that is affected? There is mostly the lower lobe that is affected. Lower lobe is mainly affected. You have something called as a Ghon complex that is there. Ghon focus will be there, plus hilar lymph node, plus the presence of hilar lymph nodes. Then you have something called as a secondary tuberculosis. Now what happens in secondary tuberculosis? In secondary tuberculosis, there is mainly reinfection or the reactivation. There is mainly reinfection or reactivations of the infections that was there earlier in that person. So it is located at the apex of the lung. The features will be, there will be caseating granuloma, cavity lesions will be there, and spread is via the local roots. You have something called as the miliary TB, that is widespread hematogenous dissemination will be there. There will be millet seed-like nodules. Have you seen the millet seeds? They are so small millet seeds are there, right? Then you have extrapulmonary TB. There are lymph nodes or TB. There are most common form. Most common form is lymph node TB. Intestinal TB, most common is ileocecal regions. Genitourinary TB is mostly seen in the stolidity, and in the bones one is seen mainly in the Pott's spine. In the CNS, TB is seen mainly in the meningitis. What are the clinical features? The clinical features that you will have, there will be a low grade. Then there will be night sweats. There will be sputum. Obviously, there will be sputum, and very characteristic weight loss, malaise, and anorexia will be there. What is the screening that you do? You have something very famous called as the Mantoux test. It is done intradermally, intradermal. Okay, you have the readings are available at 48 to 72 hours interval. If it is positive, how you will say if it is positive? If it is more than or equal to 10 mm, then it is positive. False positive in BCG when the patient takes the BCG vaccine and the NTM infection. In the chest X-ray, you will be able to see if it is primary, you will be able to see the hilar lymph nodes and the Ghon Focus. In the secondary, you will be able to appreciate the apical infiltrates. In the miliary one, you will be able to see the millet seeds. In the miliary one, you will be able to appreciate the millet seeds. Okay, what are the complications? There will be pneumothorax. There will be fibrosis and amyloidosis. And we have read about amyloidosis in our journal pathology lectures, and you are supposed to watch that lecture. Okay, what is the treatment? See, treatment your pharmacology faculty will also tell you, but let me just be very clear. For the treatment, you have something called as the HRZE regimen: isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. You have to read the side effects very thoroughly. The regime that we used for the intensive phase, you use the HRZE regimen, and for the continuous phase, that is for the 4 months, you use the HRE regimen, and the total duration of the course is of 6 months. Okay, so I hope I made myself very clear. This will be asked as a long question, or it can be asked as a short questions. If you are having any sort of doubt, please feel free to reach me, feel free to DM me. Thank you so much, and we are done with this chapter.